Hello, everyone. My name is Danielle Cunningham, and I'm the trainer that is going to be leading you through our dissociative disorder training. So, first, we're going to start off with objectives. And so, the objectives of this training is to define dissociation, understand the core characteristics of dissociative disorders, identify three types of dissociative disorders, recognize common signs and symptoms of dissociation, discuss common myths of dissociative disorder, and learn to support residents who experience disassociation. So, first, we're going to go into what it means to disassociate. And so, during traumatic events, disassociation can occur to help endure and tolerate what might otherwise be overwhelmingly or unbearable. It essentially serves as a psychological defense mechanism, allowing the person to disconnect from the trauma in the moment to protect themselves from the full emotional impact. Now, disassociations can manifest in various ways, such as feeling detached from the body, like your resident may be observing themselves on the outside, or having difficulty recalling important personal information. Disassociation can happen in response to stress, trauma, or intense emotions, and for some people, it may become a persistent experience. A resident may escape reality through disassociation, often to cope with overwhelmingly stress or trauma. This escape can indeed cause significant problems in managing everyday life as it interferes with memory, perception, and identity. Now, during a traumatic experience, such as an accident, disaster, or crime victimization, disassociation can help your resident tolerate what might otherwise be too difficult to bear. In situations like these, residents may disassociate the memory of the place, circumstances, or feelings about that overwhelming event. Mentally escaping from the fear, pain, and horror. Now, this may be difficult to bear later. This may be difficult to later remember the details of that experience as reported by many disasters and accident survivors. It is a protective measure where your nervous system creates a disconnect between you and your body or even your surroundings. This is helpful in the moment, but dissociative states can arise long after the trauma has ended and disrupt everyday life. So, looking into what a dissociative disorder is, they are mental health conditions that involve experiencing a loss of connection between thoughts, memories, feelings, surroundings, or even a sense of identity. So, some examples of mild common disassociations include daydreaming, highway hypnosis, or getting lost in a book or movie, all of which involve losing touch with awareness of one's immediate surroundings temporarily. Now, these are normal experiences which give our brains a break and allow for creativity. So, criteria for mental health diagnosis may be met and treatment may be recommended when disassociations become distressing, out of a person's control, and or interferes with their daily functioning. So now let's look into the causes of dissociative disorder. So the first one there is going to be unpredictable family environment. This can also look like childhood trauma. Now, an unpredicted family environment characterized by chaos, inconsistency, or frequent changes can have a profound impact on a child's emotional and psychological development. When a child grows up in a home where routines, family structure, or living situations frequently change, it creates an environment of uncertainty, fear, and instability. And so these factors can contribute to the development of dissociative disorders. Next is going to be traumatic events. Now, military personnel and veterans who have experienced these horrors of combat, such as witnessing violence, killing, or being directly involved in life threatening situations, are at risk for developing dissociative disorders. Now, combat trauma often leads to post traumatic stress disorder, but in some cases, it can lead to dissociative experiences as well. A single or a few unrelated abuse events will not cause dissociative disorder. The onset of symptoms may begin in childhood, but will not be diagnosed until a person has reached adulthood. Some causes can be substance use. Now, whether it involves alcohol, illicit drugs, psychedelics, or the misuse of prescription or over the counter medications, this can be significant. This can have a significant impact on a resident's mental and physical health, their relationships, and overall well being. Now, residents with dissociative disorders may use substances to cope with the overwhelmingly emotional and psychological distress that comes from their experiences. Conversely, substance use can worsen or exacerbate dissociative symptoms, creating a cycle or pattern of self medication or worsening mental health symptoms. Sleep deprivation is also another cause. So, not getting enough rest, a state where residents do not get enough quality sleep or has a lack of sleep altogether. And then lastly, there is going to be head injury or brain tumor. And so head injuries and brain tumors can have a significant impact on brain functioning, potentially leading to symptoms like those seen in dissociative disorders. Physical damage to the brain, whether from trauma or the presence of a tumor, can affect various cognitive and emotional processes, leading to issues with memory, identity, and a sense of self, all of which are central components of dissociation. So now we're going to go into discussing the three types of dissociative disorders. And so they are dissociative identity disorder, DID, dissociative amnesia, which can also be known as localized amnesia, and depersonalization, derealization disorder. And so in our next couple of slides, we're going to kind of break down these three and kind of talk about these a little bit more in depth. So the first type of dissociative disorder is dissociative identity disorder, DID. Now, is indeed a complex and profound mental health condition where residents may experience the presence of two or more distinctive identities or personality states that can alternate in control over that person's behavior, thoughts, memories, and their sense of self. Previously known as multiple personality disorder, DID is often deeply intertwined with experiences of severe childhood trauma, especially prolonged abuse. Can also be associated with overwhelmingly experiences of that traumatic event and or abuse that occurred within childhood. Now, residents with DID may often experience sensations of being possessed by other identities or personalities. This feeling is a core symptom of DID, whereas different alters, distinct personality states, take control of a person's behavior, their thoughts, and experiences at different times. Now, the resident may feel as though they are not in control of their own actions, or that they're being overwritten by another personality. And so in our next couple of slides, we're going to discuss the symptoms of DID, which are characterized including identities, memories, and distress. So the distinct identities are accompanied by changes in behavior, memory, and thinking. And so these signs and symptoms may be observed by others or reported by the individual. This can also look like switching between different identities. This can occur rapidly, often triggered by the stress of those situations. And so when we talk about switching, this refers to the rapid or sudden transition between identities. This can happen unexpectedly, and the change can be triggered by stress, emotional distress, or specific situations that are overwhelming for your residents. So, identities can look like having two or more distinctive identities or personality states. They can each have unique names, voices, gender, and mannerisms, and the identities may have different levels of familiarity with each other. Next is going to be memory. So DID is characterized by memory gaps in memory about daily events, personal information, and or past traumatic events. Time loss. And so the term time loss refers to a resident suddenly becoming aware of their surroundings and having a period of recent time, such as previous day or that morning's activities, completely lost from their memory. This relates closely to amnesia, in which a resident loses a specific memory or set of related memories. Both can be quite traumatic for the resident, as they are left confused or unaware as to who they are or what is going on. And then next is distress. It is characterized by distress. And so symptoms cause significant distress or problems in social, occupational, or other areas of functioning. And so this signifies that the symptoms are not just causing discomfort, but they are also significantly impacting a person's ability to function in their daily life. including their social interactions, work or school performance, and other important areas of their life to the point where it causes distress or impairment. So, this can also look like depression, mood swings, and difficulty fully trusting those relationships. It can also look like self injury or suicide. These are very common. So now we're going to go into characteristics of DID. So the first one here is going to be memory gaps. So as previously discussed, residents with DID may forget events that happened while other identities was in control, meaning they cannot recall important personal information, everyday events, or even the traumatic event from their past. It can also look like detachment. And so residents with DID may feel detached from their experiences with this, with disassociation. It can act as a defense mechanism that can cause them to feel disconnected from their thoughts, feelings, memories, and sense of identity. Confusion. And so residents with DID may feel confused about their experiences due to the presence of those memory gaps. So sudden shifts in identity and a feeling of detachment from their own thoughts, emotions, and actions, which can lead to a sense of not feeling or not fully understanding what is happening to them, feeling uncertain about their identity, or having a sense that they do have multiple people or multiple identities inside. Stress. Residents with DID may experience stress from having not me experiences. And so the not me experience is a common trait among most residents who have a diagnosis of DID. Not me thinking involves doing or saying something that and then claiming that the author did it. Shock. Residents with DID may feel shocked when they learn that they do have multiple identities. It's frightening or can be for residents to find out that they have personalities in their heads and that they have been there for years, or their alters are present and they don't even know anything about them. And then feelings. Residents with DID may feel overwhelmed, sweaty, or nervous. These feelings can be caused by anxiety, which is common for residents with DID. Some additional characteristics is alters. And so alters are different identities that people with DID may experience. Each alter may have different behaviors, memories, they may have unique names, different voices, genders, mannerisms, and etc. And so amnesia. Residents with DID may experience gaps in memory or amnesia. This can include not remembering events or finding themselves in places that they don't know how they got to. Dissociative fugue. Residents with DID may experience episodes of dissociative fugue. This is a rare mental health condition characterized by a sudden or unexpected loss of memory and identity, leading to a resident traveling to a new location and assuming a new identity. Physical differences. Alters may have different physical differences, such as allergies, handiness, so the tendency to either use their right or their left hand, or even having eyeglass prescriptions. The aggressive tendencies. This can look like some alters may have aggressive tendencies towards others or their other alters. The aggression is either directed towards others outside of the system or even toward other alters within the same system. Acting as a protective mechanism against perceived threats or trauma triggers. And then identity switches. Sudden shifts in personality behaviors and appearance that can be accompanied by changes in voice, mannerisms, or even physical symptoms. So now we're going to go into discussing the difference in men and women when it comes to DID. And so additionally, there are notable gender-related differences in the presentation of and diagnosis of DID, which can contribute to underdiagnosis in certain populations, particularly among men. Women are more likely to receive a DID diagnosis compared to men due to their tendency to openly present dissociative symptoms, while men may deny their experiences or exhibit more outwardly aggressive behaviors, potentially leading to underdiagnosis in the male population. Now, whether as a result of social conditioning or because of a general increased likelihood for women to suffer a significant traumatic abuse as children than men do. Women are 3 to 9 times more likely to be diagnosed with DID than men. Furthermore, women also tend to have more distinctive identities or alters, averaging over 15 compared to men who average over 8. That's a difference between. So women are more likely to be diagnosed, and men are more likely to deny their symptoms and trauma histories, which can lead to elevated false negative diagnosis. So now we're going to go into dissociative amnesia. And so this is the second type of dissociative disorders. It can also be called selective or localized amnesia. And so it is a type of dissociative disorder that is characterized by the inability to recall important personal information, usually following a traumatic or stressful event. This memory loss goes beyond what would be considered normal forgetfulness or a usual lapse in memory that occurs due to everyday stress or emotional experiences. And so, dissociative amnesia may surround a particular event, such as a combat or abuse, or more rarely, information about the identity and life history. The onset for amnesia episode is usually sudden, and an episode can last minutes, hours, days, or rarely months to even years. There's no average for age onset or percentage of dissociative amnesia, and the resident may experience multiple episodes throughout their life. The main symptom of dissociative amnesia is memory loss that is inconsistent with normal forgetfulness. The amnesia may be for a discrete period, for certain types of experiences, or for a large portions or childhood. Now, dissociative amnesia can look like trouble recalling information from your life. And so this can look like walking into a room and forgetting why you went there, or being unable to remember the name of the close friend or someone you've known for years. Difficulty recalling information from your life can sometimes appear as simple lapse in memory, like walking into a room and forgetting why you were there. Now, for residents who have experienced trauma, the process of recounting or even remembering the traumatic event can be deeply distressing and may lead to re traumatization. This is particularly true for those with conditions like dissociative amnesia, where the memory of the traumatic event is often buried or blocked out as a coping mechanism. Now, the information that is forgotten is usually easily remembered when prompted. Your resident can name a restaurant they went to while they were on vacation a few months ago, while they may not be able to recall it on their own. If someone mentions the area they visited or a specific dish that they had, the name suddenly becomes more clear. This happens because our brains often store a lot of information, and sometimes the right cue or trigger is needed to assess that information effectively. Memory loss related to substance use, particularly alcohol or drugs, can result in what's commonly referred to as a blackout. And so this is a type of temporary impairment that occurs while residents are under the influence of substance, and they may be unable to recall what happened during that time, even though they were awake and conscious. Amnesia can be about specific events or life history. And so could be about residents who was unable to recall details of a car accident that they were involved in, despite remembering other aspects of that day. While an example of amnesia related to life history may be a resident who forgets their childhood completely due to a traumatic experience, including their family and potentially where they grew up at. Now, there are different types of dissociative amnesia. And so the American Psychiatric Association notes that dissociative amnesia has several presentations, including localized amnesia, which is the inability to recall specific events within a limited time period. Selective amnesia, which is the inability to recall specific details of a traumatic event. Generalized amnesia, which is the loss of memory about one's entire identity and life history. And then systemized amnesia. This is the inability to recall memories related to specific theme or categories such as childhood abuse. And so in our next couple of slides, we're going to break these down a little bit and talk about them a little bit more in depth. So first things first is going to be localized amnesia. And so an individual experiences a complete loss of memory for a specific period of time. It is typically caused by a traumatic or highly stressful event, such as accidents, natural disasters, military combat, sexual assault, or witnessing a violent crime. It specifically involves gaps in memory for a defined period of event, often due to trauma or high levels of stress. Now, these memory gaps typically focus on traumatic or stressful experiences itself rather than everyday life of non-traumatic events. The memory loss may not appear immediately following the traumatic event. It could surface hours, days, or even months later. But it is common for the forgotten period to be relatively clearly defined, such as a few days or weeks during a traumatic event, or even longer periods of time, like years, during an abusive childhood or combat experience. And so, for example, residents may forget the months or years of being abused as a child or the days spent in intense combat. The amnesia may not manifest for hours, days, or longer after that traumatic period. Usually, the forgotten time period, which can range from minutes to decades, is clearly defined. So, typically, patients experience one or more episodes of that memory loss. Now, localized amnesia is the inability to recall specific events or experiences during a particular time period, confusion or disorientation about the missing time period, feeling like they are missing a part of their life, and that emotional distress or anxiety related to the loss of memories. And so, a key feature of localized amnesia is that it is often manifest in episodes. A resident may experience memory loss during one traumatic event or moment, but other parts of their life may remain intact. This means that they may still remember significant parts of their life outside of that trauma. Your residents may not be aware that they have lost that memory until something triggers its recovery. Now, looking into some symptoms of selective amnesia, this is the inability to recall specific details about the event, gaps in memories that may be filled with false or fragmented memories, feelings of confusion or disorientation about the missing memories, and the avoidance of topics or situations related to the forgotten event. And so, for example, a woman involved in a violent robbery, months later, she remembers everything about her life, where she works, her family, her hobbies, but she cannot remember the actual events of the robbery or even the day that it happened. All memories surrounding that trauma are blocked out. Or even a man has no recollection of his life from the ages from 6 to 10. He later learns that during that time, he lived with a relative who was abusive. His mind has essentially walled off those memories as a coping mechanism. Now, looking at generalized amnesia. And so, generalized amnesia is a rare and severe form of dissociative amnesia where a resident loses access to virtually all aspects of their personal identity and life history. This condition can be profound, affecting memories related to who they are, where they have been, and what they have experienced. Residents may also lose the ability to recall well learned skills and information that was once well known to them, such as knowledge of the world around them. And so the onset of this type of amnesia tends to be sudden, and the residents may experience it as an overwhelming loss of personal identity, which can be terrifying and disorienting. Now, looking at some causes of generalized amnesia. And so this is psychological trauma. And so this refers to a deeply distressing or disturbing experience that overwhelms a resident's ability to cope effectively, often resulting in long-term negative effects of their mental and physical health. Trauma can arise from a wide range of events such as abuse, loss of a loved one, accidents, natural disasters, violent experiences, or witnessing life threatening events. Brain injury can be a profound impact on memory function and damage to specific areas of the brain, such as the hippocampus, which is particularly associated with memory loss. The hippocampus plays a crucial role in forming and retrieving memories, and damage to the area can result in generalized amnesia. Medical conditions can play a significant role in causing memory loss. and some specific conditions such as transient global amnesia, which is a temporary form of amnesia, which can last for a few hours or a few days, kind of like Alzheimer's disease, which can lead to varying degrees of memory impairment, including generalized amnesia. But looking at transient global amnesia, it is a sudden temporary episode of memory loss that can be attributed to a more common neurological condition like epilepsy or a stroke. It is relatively rare and typically occurs in middle-aged or older adults. Now, looking at systemized amnesia, it is a type of dissociative amnesia, which is a psychiatric disorder. It is more common in residents who have experienced trauma or extreme stress, such as combat veterans, people who have been sexually assaulted, or those who have experienced abuse. So it is a type of amnesia in which an individual's lost memory for a specific category of information rather than a broader or general loss of memory. Now, looking at depersonalization and derealization disorder. And so depersonalization is feeling detached from oneself. The person may feel like an outside observer of their thoughts, body, and actions. And then derealization, this is feeling detached from the surroundings, the environment. It may feel foggy, dreamlike, visually distorted, or emotionally disconnected. And so depersonalization, derealization disorder, DDD, is a dissociative disorder characterized persistent or recurrent experiences of depersonalization, derealization, or both. It can be extremely distressing and can be often misunderstood. So now we're going to watch a video. And so in this video, we'll watch Joe's story. He's going to discuss his experiences with depersonalization and derealization and his unique perspective and journey.
Nobody's ever really heard of this condition. It's very, very common. 1% of the general adult population are thought to have it to a clinically diagnosable level. So it's on par with something like schizophrenia or OCD, which everybody's heard of, and there's a lot of NHS services equipped to kind of assist with. But so it's very common, but you can spend years and years going through doctors and these sort of mental health partnerships and getting assessments and being referred from one person to the next and to the next and back to the original person and onward again. And I think the average diagnosis time for this condition is 7 to 12 years. So my condition is depersonalization disorder, depersonalization, derealization disorder, whatever. I think it's 75% of people experience both together, DP and DR, where you can get them independently, but most people experience both. You're looking around, but you feel like there's a pane of glass between you and everything going on. It's as if, words are coming out of your mouth, but you don't feel like you're consciously thinking them up. They just kind of happen, and somehow you make sense. You walk to the bathroom and walk back again, and you're not really sure how you're putting one leg in front of the other. You're just kind of doing it. The lack of help, I think, is probably the most difficult thing, and it's certainly something that I've said to people before, that yes, living with the condition is hell, but the grind of dealing with the mental health services is often worse. Where I find myself nowadays is I've been through all the help I can access, and I'm now worse than when I started, significantly worse. I've tried everything possible. I've tried every medication I can get somebody to prescribe for me, and nothing's made a difference. And now I find myself still getting worse, having every angle I've tried become a dead end, thinking, well, where does this stop? What does my future look like? Because I'm struggling so much now. I'm only 32. What's this going to be like when I'm 60? Is it going to carry on getting worse? Is that a future I feel I can get motivated by? If there's no emotions there and it's all is going to be this sort of dark cloud, it's very difficult to feel positive about the future. I want to see the healthcare keeping up with the growing awareness in the condition, and more clinics opening, more mental health partnerships being aware of depersonalization, having clinicians trained in treating it, and just taking out some of that stress of dealing with the mental health services, trying to fight to get to somewhere where you need to be, but meeting resistance the whole way. So that's what I want to see happening in the future with depersonalization.
All righty, so let's talk about some core symptoms of depersonalization. And so, for residents that experience a feeling of detachment from oneself may feel as if they are an outside observer of their body. Um, So, feeling of detachment from oneself, they may describe symptoms as a robot dream like feeling, and these sensations of being emotionally or physically numb. And so, residents may use language like, I feel like I'm watching myself on the outside. I feel like I'm not real. My voice doesn't sound like mine. And so, residents may describe feeling like they are in that dreamlike and robotic or lack of control over their speech or movements. And so sensations of being emotionally or physically numb or feeling that one's body parts are distorted. So some additional ones is detachment from one's surrounding. This can involve feeling that the world is unreal, a dream, or a movie. And so residents with derealization are usually aware that the world hasn't changed, but they just feel and have a thought that it has. So to residents, sounds may seem muted, colors may appear dull or overly bright, and that feeling of being in a movie or behind a glass wall, um, like there's a sense of like someone is watching them from a distance, as if there's a barrier between oneself and the world. Feeling like the world is distorted or unreal. Objects may appear foggy, flat, or have an unnatural shape. These symptoms are often reported during stress, anxiety, or trauma, and are accompanied by um, a strong internal sense that something is off. But again, residents retains insight that that is a perception and that is not the actual reality. Emotionally disconnected from others from others, and so residents may feel like they are separated from a loved one by a glass wall or a fog. This symptom can severely impact relationships, but it is important to remember that the capacity to feel is still there. It is just being blocked or suppressed by the disorder. And so distortions in time, perception, space, or distance. And so time may feel like it is slowing down. Sometimes time may feel like it is speeding up, or time is just standing still. So, looking at that, who am I? So, dreamlike or unreal sensations is derealization. So, that disconnection from the environment. And then that robot like autopilot or feeling not in control is depersonalization, which is a disconnection from self. Now, both are coping mechanisms of the brain under that extreme stress and trauma, but it is also a way to shut down those overwhelming experiences that your residents may have. So when we talk about risk factors and suicide risk, and so residents who have experienced physical and sexual abuse in childhood are at increased risk of dissociative disorders. Most individuals who develop dissociative disorders have experienced repetitive, overwhelming trauma in childhood. Among residents with dissociative disorders in the US, Canada, and Europe, about 90% have been victims of childhood abuse or neglect. Now, suicide attempts and other self-injurious behaviors are common among people with dissociative disorders. More than 70% of outpatients with dissociative disorders have attempted suicide. And so many residents with dissociative disorders experience suicidal thoughts or may have challenges with self-harm behaviors. Now, let's talk about cultural and religious considerations. And so, in many cultures, mental illness carries stigma, which can delay treatment or prevent individuals from disclosing symptoms. Beliefs about mental illness influence help seeking behaviors. And so, some may go to religious or traditional healers first, while others may avoid care entirely. Now, according to the DSM-5, in some cultures, dissociative states may be normal parts of religious or cultural practices. These must be distinguished from pathological disassociation. Now, the DSM-5 recognizes that trance states, spirit possessions, and altered states of consciousness may be common and accepted in many cultures and should not automatically be viewed as signs of dissociative disorder. Now, when we look at the culture and interpretations of disassociation, the distinction between normal versus distressful disassociation depends heavily on cultural context, intensity, frequency, and functional impact. Now, in some cultures, dissociative experiences are seen as normal or even desirable, especially during religious or spiritual practices. This can complicate distinguishing between culturally sanctioned behavior and clinical dissociation. Now, symptoms of disassociation may be explained through spiritual beliefs like possession or ancestral communication, leading to residents to seek help from spiritual healers rather than mental health professionals. Now, looking at normal disassociation. And so, normal disassociation is a common psychological experience that does not indicate a mental disorder. These are temporary, not distressing, and do not impair daily functioning. So, some normal disassociation includes like daydreaming, getting lost, driving in autopilot or not recalling parts of the trip, mild detachment during stress. But again, these are temporary, not distressing, and do not impair their daily functioning. Now, looking at pathological disassociation, it is, by contrast, involuntary, persistent, or recurrent, disruptive to functioning and sense of identity. And so, amnesia for daily events or personal information. Looking at derealization is feeling attached from oneself. Depersonalization. Derealization, feeling the world is unreal. And these symptoms often emerge from trauma, particularly early life abuse or extreme stress. So now we're going to go into how to support our residents with dissociative disorders. And so first is always treatment. Treatment can involve a combination of therapy, case management, and support groups. For therapies listed above, staff would need to be licensed or trained or be a trained mental health professional to provide these therapies. So psychotherapy, this can help identify triggers and develop coping strategies. CBT, cognitive behavioral therapy, can help with those coping strategies. EMDR can help manage symptoms and strengthen self-esteem. And then hypnosis can help access alters and work through therapy sessions. Coping with dissociative disorders can involve a combination of therapy, self-care, and support groups. So this one here is self-care. So these are grounding techniques. This can help your resident feel more connected to the present. Mindfulness can help your residents accept uncontrollable events. Exercise can help reduce symptoms of anxiety and depression. Having a healthy diet can help reduce inflammation and symptoms of anxiety and depression. And then sleep can help decrease symptoms of dissociative disorder. So just some self-care techniques here. Grounding techniques are methods used to reconnect with the present moment. They are all about anchoring themselves in the here and now. They're helpful when the mind starts spinning or anxiety ramps up. So just some great grounding techniques for senses. You'll have your resident find things they can see, 4 things that they can touch, 3 things that they can hear, 2 things that they can smell, and then 1 thing that they can taste. So it's a great grounding technique for senses. These are some physical grounding techniques. These involve using the body or movement to bring awareness back. And so physical grounding breaks the loop by shifting the focus to sensations and movement in the present moment. So it's kind of like holding eyes, focusing on coloring, creating a grounding space, smell something nice, have a good savory meal. Sprint quickly, try breathing work. So all great physical to get your residents' bodies moving. Some ways to practice mindfulness. Now, mindfulness is paying attention on purpose in the moment without judgment, observing thoughts and avoiding classifying them as positive or negative, and just knowing that they are just thoughts. So, some ways to practice mindfulness is read positive affirmations, practice breathing techniques, check in with your emotions, take a mindful walk, and read guided imagery for relaxation. These are some additional mindfulness practices. So mindful breathing, mindful movement, and 3-minute breathing space. Many everyday activities can be done mindfully using all senses. And so, for example, washing the dishes and feeling the warm water, smelling the dish soap, seeing a pile of clean dishes. These are all really good mindfulness practices. And so, for someone with dissociative disorder, such a practice can help connect with what is real, who they are, what they are doing in the moment, while attempting to not make judgment about their current situation. Memory problems is also another great one. Discuss how your clients with amnesia can benefit from this intervention. And so just being able to notate the activities that they do on a day-to-day basis, the time that they do that, just making sure that they can recount the things that they did. If they do happen to lose that memory, they can always have a memory diary to kind of go back to. But spot the early warning signs. Another way to help your clients is being able to spot those warning signs. And so pay attention to other symptoms and warning signs. There may be other related symptoms occurring if a resident has dissociative disorder, which were not reviewed in this training, although the other symptoms may not all be necessary for a diagnosis. So pay attention to your residents' mood, their personality shifts, that may seem unrelated to the current situation. Pay attention to their extreme emotional reactions, which can lead them to talking to themselves or talking in third person or referring to we or they when they describe their personal experiences. Consider trauma history. Dissociative disorders typically arise because of years of extreme abuse or repeated trauma. And so this typically occurs because of chronic abuse in a resident's life. So a resident will typically experience years of emotional, physical, or sexual abuse as a child, and they may develop dissociative disorder. Keep track of time loss and amnesia. So use the diary that we discussed on the previous slide. This is kind of will help your clients identify patterns or triggers there. And then spot dissociation. Dissociation is the experience of feeling detached from their own body experiences, feelings, and memories. Everyone experiences dissociation to some degree. However, someone with dissociative disorder may experience dissociation more regularly, as if they are in like a waking dream. And so also going back to them feeling like they are watching themselves outside of their body. So just make sure that you are able to spot the warning signs there. And so, in conclusion, dissociative disorders are complex, often misunderstood, and deeply rooted, tied to both trauma and cultural context. And so, with the appropriate diagnosis and trauma informed care, individuals can manage symptoms and improve quality of life. And so, I want to thank you all for your attention and taking this training. And hopefully, this training has increased your knowledge on dissociative disorders. Thank you.